Well, good afternoon, everyone, and welcome to the latest installment of Learn at Lunch. Today we've got back with us Dr. Jeff Rich doing his impacting patient care with Chiropractic Radiology, and I know he's got some more interesting cases for us to present. So again, it helps if you will keep yourself on mute, but when he has questions or is asking for comments from you, or if you have any questions or comments, just unmute yourself and hop in. So with that, Dr. Rich, take it away.
Well, thanks, Jeff. It's good to see you again, and looking forward to sharing these 6 cases with everybody today. Last time we've been under 8 feet of snow since the last time we talked together, and I heard you guys are staring down the barrel of 20 more inches. And here in Lakeville, I think they were saying about 14 inches of snow. So all I can say is I apologize. It's not my fault. But let's enjoy, let's have a good time here, and then hopefully get this hour done and learn some things. And maybe you can take a day off and build a fire and hang out with your family while you get snowed in. Just to review, and I do want you to unmute yourself and play along. It's way hard on me to just speak to this computer without talking to you guys. And plus, I know you guys would be fun to hear your voice. So, to remind you, I'm all about process, and I'm bringing always, I think, the top 8 or 9 cases that I've seen since we last talked. And I'm going to continue to bring great cases and just show you what I'm learning and share with you some new things and review some boring things just to make sure you're up to speed. But we're going to be doing the 4 Ds. And so we'll have some questions that talk about where is the abnormality. So this is not just me speaking to you, but it's you speaking to me. It's you interacting and finding yourself, doing radiology, describing it, coming up with the differential, and then telling me, and maybe even having a discussion, how in the world this changes anything come Monday morning. So don't forget the 4 Ds. This is how I teach at Northwestern, and I found that this is really how it works in practice. So here we go. Let's get to some cases. Now, before I do this, the first cases, there's going to be a little quiz, 6-question quiz. I think it's easy, but I thought all my tests were easy in school. So I'm going to make sure that you're paying attention here for the first few cases, and I'll make it really clear, because and if I were you, I don't know, Jeff, if we can do this, but I would just go ahead and get that little quiz out of the way, and it'll be easy if you do that right now after the class. Okay, first case is a 67-year-old male with hip pain, and in the current pretty bad hip pain, and it's true hip pain. It's not over the SI joint, when people talk about hip pain, but it's true anterior intrinsic groin and medial thigh pain. So true hip pain. But he did have years ago a soccer injury to the upper leg as well. So both of those nuggets are important. So here's the picture. All right, so take a look. And normal or abnormal? Does this film look normal or abnormal?
Abnormal.
Okay, obvious, good. So that's the first step. And do you think that this is SI joint pain, hip pain like everybody else talks about, or is this true hip joint pain? All right, not a hard question, but everyone see it? Is it true hip pain? Yes or no?
Yes.
Yes. Good. So we're on it, and immediately we want to jump to the diagnosis here, and so why don't we take? Let me just give you a multiple choice here. Would you go RA, or would you go OA here? 50-50 chance.
OA.
Right, and good. I agree because we have basically bone-on-bone narrowing of the superior compartment, but it's non-uniform. It's narrowed up here. It's still still have joint space medially. You've got osteophytes coming off the medial aspect of the head. But, and I'm going to go ahead and just take a closer look at this for you. Now, look at the femoral head for a moment. How would you describe the so we're moving from detection, you already did that. In fact, you got the diagnosis of severe osteoarthritis. But that femoral head, what do you think about that femoral head? Is it, what's happening there?
Reduction in bone density and a lot of early geode formation.
Good, good. So right in the top part of the femoral head, there's kind of cystic lucency, and there's multiple cystic lucencies. I'll just circle them for you. Quite a few cystic lucencies going on here. And those cystic lucencies are probably large subchondral cysts from the degenerative disc disease. I say probably because I don't know for sure. What other condition can cause areas of sclerosis and lucency in the weight-bearing surface of the femoral head? Anybody have an idea? They can cause mixed sclerosis and lucency in the femoral head, other than subchondral cysts.
Paget's?
Did someone say Paget's?
Yeah.
Okay. Yes, that can cause, let me go back. Now, Paget's, if I had Paget's here, what I would see is more thick cortex all along the edge, and then trabecular striations like this. You can get lucency of the Paget's with the so-called flame sign, but that is typically the blade of grass. It's really pointed. It doesn't cause circular lucencies. Other thoughts that would create lucencies in the hip? Myeloma, yeah, punched out lesions from multiple myeloma, or yeah, metastatic disease. All right, what can cause mixed sclerosis, lucency, fragmentation, and collapse of the femoral head?
Chandler's disease.
Good, good. Avascular necrosis. Yes, AVN. And here's the deal on this case. I think there could be AVN here because whenever you get such significant cystic change within the femoral head, yes, it could be subchondral cyst. Degenerative disease in the hip can cause large subchondral cysts, but this appearance, I can't rule out superimposed avascular necrosis. Now, does that matter whether this is avascular necrosis or not?
Probably not, because his hip is shot anyways.
Okay, that's a good answer. I mean, it's a gutsy answer because, you know, the academic guy in me is going to say, of course it matters. I always want to be right. But the answer is, you know, that hip is shot. That is bone on bone, constant pain. If there's AVN here, he's going to probably need a new hip anyways. And so it's a bit academic, but I'm just trying to let you know that bad degenerative change can also cause have AVN be a secondary sequelae of that degenerative change, or the AVN came first and you had secondary degenerative change. At the end of the day, you guys agree? I mean, come on. In my experience, this guy's going to need a new hip. Am I right?
Yes.
Yes.
I mean, we can only do so much here. Now, good. So that's good discussion. Now, there's another finding here. Let's see if I have, let's go to the next. Let's go to the frog leg view. All right, take a look at the frog leg view. And what I like about the frog leg view is you can see a subchondral cyst in the supraacetabular region. Of course, you can see the cystic change and the degenerative change in the hip. But remember, there was a soccer injury to the thigh, and there's another diagnosis here. All right, let's have some fun, and we got to get to that next case here. Do you see any other findings on this patient?
There's calcification in the soft tissue about mid-thigh, medial
Good.
thigh.
Good. Right there, right, Doc?
Yep.
Okay. So good pickup. And again, I liked, we've got plenty of findings in the bone, plenty of findings in the joint, but we don't want to get search satisfaction. There's another finding in the soft tissue. So we always go technical alignment, bone, cartilage, and soft tissue. We don't stop. We don't get search satisfaction. We look all the way through the soft tissues, and now we see some of that. Now let me see if I can expand that to see it a little better for you. You can kind of see it. It's linear region of sclerosis. Now, with a history of an old soccer injury, what's your best diagnosis here? Anybody?
Myositis ossificans.
Good. Good. I agree. This is probably kind of a linear, kind of intramuscular or kind of right along muscle fiber form of old myositis ossificans. So it might indicate, especially that you do some Graston or ART or myofascial release, or you might, this could be an indication, not that you need surgery, of course, but there's been old trauma there, and there's probably some significant adhesions and things, and perhaps if you work on that, some of the things they're calling hip pain, maybe some of that hip pain is coming from here. And so clinically, that's what I would do. So good job. You guys are 1 for 1. First case is degenerative disc disease, probably with large subchondral cysts. Can't rule out AVN, but also a secondary diagnosis of linear myositis ossificans. All right, good. Next case. Okay, first, as I get to the picture, I want you to detect. I'm going to shut up. Believe it or not, it's hard for me, but I'm going to shut up, find the finding, because many of you guys Twins fans, they're starting out pretty well, aren't 5-3. Whenever they actually have more wins than losses, I think they're going to win it all. Hope springs eternal for Twins fans. They play tonight at 6:15. Tune in. We're not missing it right now. Okay, we're not missing it. Second, so find it, number 1. Number 2, is this old or new in your opinion? Don't worry about old or new. We'll get to that. But first of all right, and jump on it. Whoever sees it first wins. If I could throw candy at you, I would. But all right, here we go. 1, 2, 3. Here's the picture. What is the finding? Where is the finding?
Fractures, scaphoid.
Good. So you go here in the scaphoid, and there's that scaphoid does not look normal. The most common fracture of the wrist is the scaphoid fracture. That might show up on your little quiz. Come on, that's easy. The most common wrist fracture is the scaphoid. Here it is. By the way, the second most common is the triquetrum. Third most common is the capitate. And in fact, that forms a bit of an arc. Check this out. This is cool. Review this with you. Fractures happen along this arc. Radial styloid, ulnar styloid, scaphoid, trapezium, and then capitate. Pretty cool, right? That's where they happen, is that arc. Now, I like that we don't have widening of the scapholunate joint space that can be associated with the scaphoid fracture. That looks nice and narrow. Question though, and I'll blow it up for you. Question number 2 then is, do you believe, in your opinion, is this an old fracture of the scaphoid or a new fracture of the scaphoid?
Old.
Okay, we got a vote for old. Any other opinions? We got 1 vote for old.
I vote for new.
Okay, we got
New.
we got one old, we got 1 new, we got 1 new. Any other votes? Okay, we got some votes here. Let me go back. All right. So if I'm looking at this fracture site, notice at the fracture site, can you guys see that little white hand there?
Yep.
Okay, good. Sometimes I just gotta make sure. So rubbing the fracture site here. And that fracture site, if you look at the margins, it's got a sclerotic rim around those fracture margins. So I would favor old here, because if you look at the edge, yes, it's irregular. Yes, it hasn't healed. All of that's true. Yes, I also think that there is cystic change and sclerosis of the proximal pole related to probably superimposed avascular necrosis. But I think this is probably an old fracture and has gone on to non-union because of the rim. Now, again, you're going to have the history. I'm teaching you radiology today, though, so from a radiological standpoint, it's probably old. Now, sure enough, we asked him more questions. Recent case, kid was a semi-pro lacrosse player, had an injury in lacrosse 4 months ago. Kind of blew it off, young 20-something, and kind of felt a little better over time. Still hurt a little bit, but kind of blew it off, didn't get an x-ray, and then it started hurting worse. Well, because he's going back to sports, and now we're getting micro motion right at that fracture site. And sure enough, it's an old fracture. And these scaphoid fractures are rough. You do not want to miss a scaphoid fracture. And so my opinion on these scaphoid fractures, if you have any pain in the snuff box, my opinion is get a scaphoid view. Scaphoid view, and that's P to A wrist with ulnar deviation and 30 degrees of tube angulation towards the elbow. Okay, so basically ulnar deviate, put the central ray right over the scaphoid, but angle it towards the elbow, angle the tube towards the elbow. That elongates the scaphoid. I just haven't missed, I don't think, a scaphoid fracture with that specialized view. And this is the most common fracture of the wrist, but it's also the most common, commonly missed fracture as well in the wrist. So subchondral cisco with degenerative joint disease, and the most common wrist fracture, the scaphoid fracture. Questions on this case, guys and gals? Whoever's there, I don't even know. Everybody.
With the nine, what would be, the treatment options? Is there anything with the pins?
That's a good question. I was working with a hockey player who they screwed up and missed a scaphoid fracture, and the guy wanted to go pro. Who can blame him? And so they actually said, well, here's what they can do. They can resect. They can resect that proximal part. Sometimes they put a plug in there. They also can get in there and basically get in there and rough up those surfaces, get them all bloodied up. And then they can put what's called a Herbert screw in there and hope that it takes. So yes, aggressive sports-related expert surgeons, probably not general orthopedists, but somebody who knows what they're doing, no offense, in the extremities, can probably get that to heal up, but it's a major project, and I think that they're going to try it on that hockey player. Good question. Other questions? All right, so a couple of easier cases. Let me give you a harder case. Okay, old surgery. And so tough question. I know we look at quite a few post-surgical cases, but I'm with you. It's not really our expertise, but let me teach you some things about that. So here's an old surgery. So take a look. Okay, there it is, lower leg. Question number one is, where was the surgery?
Tibial plateau, probably.
I think the tibial plateau is okay. I do think that I see that lucency that you're seeing there, but I think that's okay. I think that lucency is a mock effect across there. Okay, keep looking. Whereabouts was the fracture? Anybody see anything?
Probably the distal tibia fibula.
Yeah, kind of like Tommy Boy, not so much here, not so much here, more in here. And yeah, and you can see it. It's kind of bulbous, and I mean, it's beautiful. I mean, it's healed up really nice. The fracture has healed. There's good cortical union. There's still some remodeling. We can tell where the evidence of, there's a kind of a both bone fracture, you know, a ski boot fracture. I mean, this had to hurt. I don't know if you've seen the movie, but some would call this a misery fracture, but I'll let you Google that another time. Anyways, there's been a fracture, nasty fracture. In fact, I believe a variant of this was, who was that Boston Celtics player? Really did a number on his ankle last year. Anyways, so we've got a fracture. Now, we've got a rod in the, right down the medullary portion of the bone, and we've got a screw and a screw. And my question to you is there any failure associated with this surgical procedure, in your opinion?
No.
Okay. No. Anybody else have any thoughts? Well, it's either no or yes. And one thing's for sure, it's tough to do post-surgical stuff. So let me give you some things. Number one, well, what do you mean by surgical failure? Let me tell you what you're looking for. Doesn't matter what kind of orthopedic surgery you're talking about in the hip or extremities. Number one, you're looking for lucency. You're looking for surrounding lucency. So right along the bone and metal interface, you're looking for significant lucency. Number two, you're looking for fragmentation. So sometimes you can see, sometimes you can see some fragmentation there. And that could be what's called particle disease. Particle disease. And then the other thing you're looking for is actual failure of the component of the metal. Okay, surrounding lucency, that's going to be either infection is the reason for the lucency, or it's going to be loosening. Okay, infection or loosening. So surrounding lucency is bad, fragmentation is bad. You would love to see a nice sclerotic rim around stuff, and I think you can see a little bit of a sclerotic rim down there. That's a good sign that it's nice and good. Now, that being said, let's expand this a little bit. All right, let's look for lucency around there. Let's look for fragmentation. Let's look for failure of the surgery itself, breaking of the metal. Now look, okay, look pretty good. Yep. No lucency. Looks great. We keep going. And what do you notice as you get down here?
Yeah, screw loose.
Screw.
Yeah, check out that screw. Yep. Look at that screw. That screw is fractured. See that? It's crooked, and there's a fracture right there of the screw. Now, you say, isn't there a little lucency right around there too? Well, maybe you go up to the top, and that looks better up here. So maybe just a tad of lucency down here. Not much, but I maybe question it. But then there's a broken. So this, and by the way, the pain is right here. And so I would say it doesn't look infected, doesn't look fragmented. It's not buried, but there's a fracture of the screw. This person should go back to their orthopedist. They should compare to old films. they should decide if this is going to cause some local periosteal irritation with this fractured screw, or what's going on here. Is that related to the patient's pain? Okay, so does that help for follow-up surgery?
Yep.
Surrounding lucency, fragmentation, and failure of the metal.
Okay, doctor.
Okay?
Doctor?
Sorry, one more time. Yep, hit me.
An intramedullary rod like that, that's obviously been in there quite a while, well-healed bone fractures. Is that movable?
Yeah, that's a good question. The answer is it is removable,
No,
but if you...
Can it possibly move at this point? With or without screws, functional screws?
Yeah, I don't think the actual big rod could possibly move.
Okay.
But I do think, because of the biomechanics, because of the motion that occurs at the ankle mortise joint and the stress on the in the interosseous membrane, if the guy goes back to a lot of activities, there could be some stress here that fractured the screw, and they may need to remove the screw and see if that does the job. But I agree. The only reason this would be moved is if 20 years down the line, the guy needs a total knee replacement and they want to get rid of that thing. But boy, I don't know, that I wouldn't want it removed. I wouldn't want it removed. Are you still hearing me?
Yeah, I guess that's the reason for my question. When you ask the question, is this a surgical failure or not?
Yeah.
And to my mind, it's not a surgical failure, it's a component failure. But at a point where it has no medical significance regarding the issue that you see.
Yes. Yeah, I would say, yeah, that's a good distinction. It's the surgical failure broad category should be defined very carefully here as a component failure. It's not a problem with the patient, it's a problem with the component. That's good. Good point. Okay. All right, here we go. Next case, a 55-year-old female with a history of lupus. Okay, history of lupus. All right, take a look at this picture. Got the necklace on. Love that. Gotta love that. All right. The only thing I saw on this case, I felt this was a little bit convex laterally here, and I don't really like that. There's a little prominence of the aortic arch, but whenever I have convexity on this side in the region of the hilum, I think I would follow up with a PA chest radiograph just to make sure it's okay. That's not the main reason I kept it. Here's the main reason I kept it.
Yeah, I thought so.
Look at that.
3 and 4.
Yeah, look at C3 on C4, probably forward 4 millimeters, and then 5 on 6, 7 millimeters. And then the ADI is okay, but really, and then the facets just look kind of scrambled in there. Now, if I go back now and you go ahead and take a look at the mid-cervical spine here, you're probably saying, wow, that does look a little strange in there in the mid-cervical spine. So let's go over here again. Now, in a patient with lupus, remember, lupus can kind of look like RA, and it doesn't cause erosions, but lupus causes subluxation that can be reducible. So lupus causes subluxation that is reducible. And so you wonder, is this related to the patient's lupus? And probably is the answer. Now, the fact that the mandibles are pretty well lined up, and yet I see a pedicle here, but I don't see pedicles here, would suggest that not only is it slid forward at 4 on 5, But there's a component of what? Not only anterolisthesis, but of what else?
Rotation.
Rotation. Very good. So there are multiple planes of subluxation here from the lupus. And of course, this person comes in with some mild neurological symptoms because that poor cord's trying to get through here. Of course, it hurts. And so what's your follow-up going to be on this patient? So, and honestly, there's not maybe a great one perfect answer. What's your opinion? So detection, we got it. We've described it. We kind of know that it's due to lupus-related subluxation. Now, decisions. The fourth D. What in the world are you guys going to do about this? So just throw it out there. Give me some ideas. I actually want to know what you would do.
I don't want to see a myelogram on this one. Probably,
Okay.
Probably.
Yeah. So you're wanting to see what in the world's happening to the cord, right?
Yes.
Yeah, because I mean, good. So that's one component of it. There's not a lot of space in there. And, you know, how are they doing neurologically? Are there bilateral hand symptoms? Is there leg weakness? Stuff like that. All right. We got to get through two more cases. So let me get cut to the chase here. Yes, myelogram, or probably in the Twin Cities, we would go ahead and get an MRI to see what's happening. But there's also what else is probably happening in the mid-cervical spine from a functional, instability. Right. And so how are you going to prove that?
Flexion extension views.
Right. So you could do flexion extension x-rays and MRI. Or if you had a stand-up or some kind of where you could actually do dynamic MRI, you could kill two birds with one stone. At the end of the day, I agree. I wouldn't want to manipulate, adjust mid-cervical here. I'd like to see how much is this moving around. AP translation and also disc wedging. So I think that's good follow-up here. But an interesting case of I think pretty massive subluxation related to lupus that's causing clinical symptoms. And you say, well, how in the world am I going to know that lupus causes subluxation? And the answer is, you may have forgotten that, but you know they have lupus, and you can either talk to the rheumatologist or you can Google lupus and instability, and then you'll go, oh yeah, lupus causes in the subluxation that's reducible, but not a lot of erosions, and you'd remember that from class after you Google it. The only way to get at this is to Google it or talk to the rheumatologist or me, who has just Googled it, and I can help too. All right, questions on this case? Interesting case, right?
It is. Just saying, if my patient, I took that lateral and saw that picture, I'd need a fresh pair of shorts.
Yeah, you know, I'm with you. I had a case of rheumatoid where the vertebral body was right here. It was a bilateral facet subluxation from rheumatoid. The older lady walked right into the chiro clinic, and that's the only time it was diagnosed. It was insane.
Okay.
And so this was nearly as bad. All right, good. I got to get through two more so I can get your quizzes done. And if my watch isn't lying to us, I better get to it. 28-year-old with sacroiliac joint pain. Nice case. All right, lateral lumbar view, pretty good x-rays. Pretty nice digital system we got here. There it is. All right. Where detection? Detection, the first D of detection. Where is the abnormality in your opinion? I'm not saying it's a big deal, but where's the abnormality?
Posterior aspect of the L5 vertebral body.
What level?
L5.
Okay, I agree that it's kind of in here. And I'm going to give you that. Your brain's looking at the right spot. So here's the AP view. You earn the AP view. There it is. All right. So let's now this is harder. I want you to detect again or just describe where are you seeing the finding now? Of course, there's the viewing. There's the left side of the patient. Where is the finding here?
Sclerotic SI.
Good. So on the left SI, there appears to be some sclerosis in here. I agree. What else?
Due to arthrosis.
Yeah. Right here, there's a pseudo joint with sclerosis, and it's only on one side. So what would you call the finding here at L5S1?
Bertolotti.
Yeah, good. Well, yeah, the idea of a transitional lumbosacral segment, and you can see it here that you've got a transitional level with a rudimentary kind of small disc. That's all that I saw on that lateral view. And then you have the transitional segment here, and notice that it's only one side where you get that spatulated transverse process. That forms an accessory articulation with the sacrum. And so let me just blow this up for you so you can see it better. Okay, so now I think this is a great case. And we talked about this, but gosh, I think this is important. The rheumatologist believes that this is going to be either osteitis condensans ilii or a seronegative spondyloarthropathy related to either psoriatic or Reiter's disease or atypical AS. I don't buy it. Why don't I buy it?
It's faulty biomechanics, just putting more strain on the SI joint.
Yeah, this is an awesome chiral case. I mean, this thing, you guys should be crying right now. This is so cool. Here's why. This has caused transitional segments, especially the unilateral ones like this with those accessory joints, cause some significant asymmetric biomechanical changes. And those significant asymmetric biomechanical changes cause asymmetrical Wolff's Law load across the SI joints. And it was so significant on this case that it caused increased motion over there. And then that, of course, laid down bone and created this abnormal, almost nasty-looking SI joint. That's all stress-related biomechanical change. And also, there's an increased incidence of disc herniation at the level above. And so I think both things are happening on this patient. And so instead of giving this person a seronegative spondyloarthropathy, yeah, we've got to think of the biomechanical changes that go with these really cool really cool transitional segments. So just a reminder here, transitional segments with unilateral accessory articulations definitely cause biomechanical changes across the SI joints. And those biomechanical changes can mimic a pretty significant pathology. This could be infection. This could be a seronegative spondyloarthropathy. This could be a lot of different things. But all it is stress-related sclerosis. And it proves, by the way, it proves that altered biomechanics causes significant musculoskeletal changes in the joint. Gosh, this case proves chiropractic. You know why? Because early on, this was going to, on the MRI, this SI joint was going to show up as really bright T2 signal before there were ever any changes in the SI joint. And you could image those biomechanical changes. You could image those biomechanical changes on the MRI. And I'll tell you what, if we could show that fixation causes those biomechanical changes on MRI and we can fix that, we would have our cavity, the cavity we're looking for to so that we can do wellness kind of care and get paid for it. anyways, I digress. Next case, final case that's on the quiz, and then I'll review the quiz. And if we have more time, we'll cover another case. But let's go to the last case so we get it in. All right. 52-year-old male with low back pain. And the question is not what can you see, but the question is what can't you see? So again, another detection question, trying to get you involved here. What can't you see? Go for it. Somebody jump in. By the way, a shameless plug. Check out my Duluth Pack mug. This if you ever get to Duluth, go to the Duluth Pack store. I apologize for sending there. You will lose money. It's an awesome store. The Duluth Pack. All right, I'm buying you time here. I'm buying you time by small talk, talking about Duluth Pack. Where's the what isn't visualized on this patient?
I'd call it L5.
Okay, I agree that at L5 you almost like you've got some fusion here. You've got almost like the trolley track sign or the dagger sign going on here. So there's your hint. So what is not visualized, if that's true, what you're seeing at L5? Or let me say it this way. What's fused here?
SI joint.
Exactly. And so, again, it's just like the last case now, but things that are just gone are just, I mean, am I right? Missing pedicles, brutal. I in fact, with Dr. Mick, you guys know Dr. Mick. I mean, he trained me, good guy, really good. My first case he ever gave me, I missed an arm being gone. It was a lateral thoracic view like this, and an arm was gone. And I missed it because it was just missing. And he tried to make a point that, again, things are gone. And where are the joints? There's no joints there. Here, take a closer look. Those joints are fused. And so this is ankylosing spondylitis, classic in-staged AS, fusion of the SI joints, bridging of those ligaments, some nice syndesmal fights at the thoracolumbar junction. And here's the lateral view for you. Not much here, but you might argue, and I think you'd be right, that there are fusion of the, also fusion of the facet joints. If I make the, where are the joints? There's no joints there either. And really no other findings, arguably, on this. Now, incidentally noted, let's go back. There are also here, hard to see, but up right in here you can see some calcification and in the abdomen, and you go back and it's just right on the edge of collimation. Again, I'm trying to remind everybody here, we got to look at technical alignment, bone, joint, and we see, oh, the SIs are fused. We've earned our $25. We're done. No, you're not done looking until you look at the soft tissues. This is ankylosing spondylitis with some kidney, with splenic calcification from old tuberculosis. You say, well, who cares? It's old TB. Well, what if it isn't? What if it's renal cell carcinoma or something like that? The key is to see it. Don't get search satisfaction. For this case, ankylosing spondylitis fuses the sacroiliac joints. That's an easy question. It's an easy question if you're a multiple choice radiologist. But if you're doing radiology, fused SI joints are tough to see because they're missing. Okay? Now, I'm going to do one more case. But I'm going to review the stuff you need to know for the quiz that you're going to take right away and go get your points. Am I right? So here it is. Degenerative disc disease in the hip causes large subchondral cysts. Yes, they do. The most common fracture of the wrist is a scaphoid fracture. If you have a sclerotic rim around surgical hardware, that's a good thing. But if you have surrounding lucency, fragmentation, or a broken surgical screw or rod, that's a bad thing. Systemic lupus can cause subluxation that is reducible. Yes, it can. A transitional lumbosacral segment with a unilateral accessory articulation affects the biomechanics in a big way of the SI joint. And speaking of SI joints, AS fuses the SI joints. Am I being nice or what? That's an easy quiz. All right. Let's, any questions on those 6 cases? And then I'm going to show you guys a couple more cases. We'll go to about 5 till. I don't want to, I get excited about this. I don't want to, but I got a couple more good cases. Any questions though before I show you one more case?
Quick, what is the real difference between a marginal and a non-marginal syndesmophyte? I never did.
Good question. Good question. All right, here's a non-marginal. Okay, it's coming off, not in the very. It doesn't come off right at the corner of the vertebral body. It comes off a little higher up, and it's goofy, bulky, goofy looking, funny looking. It's not symmetrical from side to side. That is non-marginal syndesmophytes, or you might have learned that as parasyndesmophytes. That is seen with Reiter's disease and psoriatic. However, syndesmophytes or marginal syndesmophytes, they're coming right up from the corner of the vertebral body to the corner of the vertebral body. And they're nice and skinny and smooth and symmetric and pretty looking like that. And that is seen with AS or enteropathic arthropathy. So that's the difference. Does that help?
Oh yeah, that's been bugging me for the last 37 years.
Man alive. Man, did you get your bang for your $2 or whatever this thing cost you for 37 years, man? We got to do this more often.
Oh, absolutely.
Hey, I got an idea. And I don't know if Jeff is here or not, but just an idea, Jeff. Jeff? No, Jeff. Remind me to tell you my idea. Okay, here's my idea. That the people who are doing these classes, maybe they, from an X-ray standpoint, because I like to do basic X-ray stuff. From an X-ray standpoint, what are some things that they'd like to know that have been bothering them for years? That'd be a fun way to bring cases. But I digress.
We can do that for the next one.
Yeah, and then I get like a list of 10 things that they, or at least 2 people say, hey, I want to know about this and this, and I at least cover their questions and then bring my own cases. Just an idea. Jeff, are we out of time, or can I do one more case?
Do one more.
All right. One more case for fun. Everything is post-quiz. This is post-quiz, not on the quiz. Here we go. Left-sided acute back pain. Again, showing you some soft tissue findings. There it is. You see it. And that is right in the area of the kidney. So those are going to be kidney stones. Here's the 25-year-old with dull upper back pain. All right, this is fun. I'll end with this one. Nice little curve there in a, 25-year-old dull upper back pain. Don't worry about is there a fracture. Where is the finding? Detection. This is so good. You're so good if you see this that you really shouldn't even have to pay for this class if you get it. I'm just kidding. I'm sure Jeff will make you, throw him a couple bucks, but you almost don't have to pay for it. If I had something to say about it, you're so good if you can see this finding. All right, where's the finding? And then I'll let you go. Where's the abnormality? Look at all 4 corners of the film. Look at the edge of the film. Hurts in the upper back. Where's the abnormality?
Soft tissue trap.
Okay, I think the soft tissue's got some digital film kind of artifact. They're okay. That's a fake out there. Okay, keep looking. Thanks for guessing. No penalty for guessing around here. Anybody see anything?
Looking through the jaw, the C2 area looks kind of funky.
Okay. All right. Yeah, don't worry about this. It is funky because of all the superimposed structures. Okay, look down here in, not right exactly there, but look on the lower half of the film. And something that doesn't look from side to side. The pain is going to be on the patient's, well, it's on the viewing, on this side, the viewing left, upper back pain. Okay, what's popping now?
Is there a slight scapular fracture, the superior scapula there? It looks like there's a lucency in the left side there, maybe.
Right in here?
Jeff, what about the
A
sternoclavicular?
little lower than that.
Okay. Yeah, I think we're starting to see it.
I'm probably hallucinating.
Yes. Is everyone's, I heard third rib. Look at that. I mean, it's kind of mean, right? It's just right at the edge of collimation.
Yep.
But look at that. I mean, there is a kind of a blown out osseous lesion here, right on the edge of collimation. Now that I circle it, you can't get your eyes off of it. Am I right?
Right.
And that's the nature of this stuff. This ended up being, by the way, a non-aggressive lesion, but it hurt like crazy. They did a biopsy. This was an aneurysmal bone cyst. Yes, it is a chiral case sent in to me within the last few weeks. A great case. I'll end with that. And I will say this, guys. You know, if you guys are looking for a chiral radiologist and you need, and once in a while you see something that goofy like this and want to get some help, go ahead and send it over to the school, to Northwestern, where I work, and we'll read it up for you. $24. The insurance pays for it, or the patient pays for it, and you can sleep at night. Not a bad deal. Use us. You guys are good. You've been doing this for 30 years, 40 years, but if you're not knowing what something is, you know, don't guess. Make sure you get help. Great case, but we're out of time. Jeff, any further comments? We'll be back in a couple months or whatever. I'll have more cases. Hopefully I'll hear from you with some things you want to see from a plain film perspective that you just always have questions on. I'll answer those questions, show you those kinds of cases if I can, and we'll go from there. Thanks, guys.
Bye, doctor.
Thanks,
Doc.
Yeah, thanks.
Yeah.
Thanks.
Jeff, anything else?
No, thanks, Dr. Rich, and we appreciate it. And as soon as I get the video downloaded, I'll send out the video link along with the test link. So should get that later this afternoon.
Okay. All right, Jeff, we'll be in touch. We'll see everybody later.
Take care.
Thank
Okay,
you.
take care. Yep. Bye-bye.